Thank you very much, Dan. Thanks for the chance to participate in this fun, ongoing robotic debate. So my position is to argue that robotic surgery is so different from laparoscopic surgery that it requires a separate component of resident education. Is it the forward button? Yeah, there we go. Okay. No relevant disclosures for this talk from me. So no robotics session is complete without, showing you the future a little bit. This is a Boston Dynamics video that dropped on YouTube about 3 weeks ago. It's their new Atlas robot, and I just want you to look at this just for a second. And the case that I'm making here is that we are about to enter a brand new world with respect to robotics. The Da Vinci system was FDA approved in 2000. That's 16 years ago. And we've been in a paradigm of thinking about surgical robotics, and the world of robotics in general, the whole world is going to change dramatically in the next couple of decades based on robotics. Here's this thing walking out in the snow, which is pretty incredible. And I'll show you a little bit later on what they have this thing doing. Now, obviously, this guy with the hockey stick did not watch the Terminator movies. But Amazon is exploring using drones instead of UPS. Are you feeling sorry for the robot right now? Most people are. But watch this. So, this is our most recent version, but the world's changing very rapidly. Amazon is exploring using drones instead of UPS and FedEx to deliver all of the stuff that you get from Amazon. Think of the number of people that'll put out of work. If that thing becomes inventory management for Amazon and your local supermarket store, think how many people that will put out of work. And then think about driverless cars. And think how many people that will put out of work. We are looking at a brand new world. And the question for us is, how is that going to affect surgery? And for all the good that Intuitive Surgical has done with Da Vinci, and I believe there is a lot of good, in this last 16 years, we've been stuck in one paradigm. And it's not what's going to happen in the world or in the world of surgery. So I believe that's also true with respect to surgical training. What is so different about the model that we currently have, the Da Vinci surgical system, that requires unique training? Three-dimensional vision is very different. There's a very different teacher-trainee physical and mental relationship. Instead of standing side by side, standing across the room, sitting at a monitor, one person at a monitor, the other perhaps at the table, or one person at one monitor, a trainer at another console. It is a very different technology to learn. And the most unique thing is that when the trainee sits down at that console, they have sole control. That's not normally the case during a traditional laparoscopic or open operation. Trainers have the ability to stop the operation, to stop potential damage, if you will, during those kinds of operations that is relinquished when you sit a trainee down at a console. So, based on those differences, why does it need to be a separate component? Well, I think there's three obvious reasons. There's probably many more, but I think these are the most obvious. First of all, hospital robotics privileging and credentialing pathway is already established, and it's already separate. We all know this to be true. If you go to any hospital in America right now and you want to do robotic surgery, you are going to have a separate credentialing pathway, and in part that is a result of the work of this society. So from the point of view of the end product and the fact that you want to go to a hospital and do robotic operations, you're going to be on a separate pathway. Second, the legal precedents already exist. Robotic legal liability has already been established, and it contains a lot of language with regard to training. Third, training programs already exist uniquely for robotic surgery, and there are more coming. So when the first consensus statement came out by our panel chair, was one of the authors, in what year was that, Dan? 2007, 2008. That paper made a very clear distinction between technical training and capability and the procedures themselves. And I would submit to you that if there is no other reason that there needs to be a separate pathway, it's this technical training and capability. So think back to the robot that we just saw dancing across the snow. Being able to program and understand how to use something that complicated is going to require a special ability. I just took a screenshot of our criteria for privileges at Stony Brook for robotic surgery. And you don't need to read the words. You can just look at it and tell it's complicated. And there's a lot of words on there. And that belies the fact that this is a separate pathway, and it's not a simple separate pathway because multiple different specialties are involved with multiple different relationships with the robotic systems. So that's the first reason. The second reason is that the legal liabilities have already been established. I took this from a website, lawyersandsettlements.com. But I mean, you could look this up and find it just about anywhere. And if you can read the fine print there a little bit, you'll see that in about the third and fourth line, harmed because of the use of the robot during surgery, sometimes by surgeons who allegedly received inadequate training. Can pretty much guarantee that almost any robotic case that goes to court is going to have some language regarding inadequate training. So it's already in the legal paradigm. We have to pay attention to that. The third reason is that training paradigms already exist and there are better ones coming. This is some very early work from Hopkins when I was there. We looked at the issue of technical training with a group of naive medical students and residents, put them on the system, and tried to ask the question, how long will it take for them to learn the technical aspects of the Da Vinci robotic system? And as this curve shows, the learning curve for both setting up the system and doing the operation was about 5 cases, or doing the task was about 5 cases. I don't think this necessarily informed the rest of the world that much, but in many cases, a lot of the privileging actually does settle on about 5 cases, proctored cases, for technical, knowing how to set up the robot and be able to use it in a safe way. Similarly, we now have the teaching console, or the driver's ed module console, and that also changes the game. That is a different way to train people with 2 surgeons at a console. And again, it's going to require a different training pathway. It's some other work from the lab at Hopkins when I was there, using the 2 console system to ask and answer the question whether a learner and a teacher together can accomplish a task better than either one separately. And this data here, just in summary, would answer that question and say yes, that both the learner and the teacher have a great advantage when they're both on a console and they're both able to do a robotic system, a robotic task together. And I will quickly admit that all of this data and most of what I'm talking to you about is with respect to the Da Vinci system and Intuitive Surgical, because that's what we've had for the last 16 years. But I agree completely with Santi, and I agree completely with Steve, that there is an awful lot more coming down the road that is going to open our world up. And there are better training programs coming. Here you see a paper about the fundamentals of robotic surgery, and I put an arrow by another past president of SAGES, Rick Satava, who was putting his heart and soul into this multi-specialty effort at the current time. So just in summary, why does it need to be separate? Three reasons among, I think, other reasons. We already have separate privileging pathways in hospitals, number one. Number two, the legal precedents already exist. And number three, training programs exist and better ones are in evolution. And just before I concede the podium to my inestimable colleague and neighbor in New York, I'll give you one example, and I think it's a good example. The urologist, the chief of urology that was my colleague in San Diego, Chris Kane, he's a military surgeon, he's very organized, he's a robotic prostate surgeon, which in many ways is the poster child for the Da Vinci system. He developed a protocol for training his urology residents in doing robotic prostatectomy. And the way he did it is he divided the operation into, I think, 12 steps, if I remember correctly, Santi. And he timed each step. And he told the residents, you are going to learn this operation step by step. If you can't do the first step within an appropriate amount of time, I take over the console. If you can, you get to move to the second step. If you can't do the second step within the appropriate amount of time, I take over the console. And he has them go to the Center for the Future of Surgery that Santi runs and do these exercises on the Da Vinci system so that they're facile. But he sits there in the operating room with a stopwatch. And if they aren't able to do the task within the proper amount of time and with the proper technical ability, he says, okay, you're done, I'm taking over, and he does the rest of the operation. And that paradigm really, really works. Those residents learn how to do the operation. Thank you very much.
All right, so taking the opposing view, we have Dr. Alphonse Pomp, who is the Leon Hirsch Professor of Surgery at Weill Cornell Medical School. Welcome to the podium, Dr. Pomp.
Thank you. So here I am, the cat with the wolves, and I'm going to tell you that robotic training is similar to laparoscopic training. Nice picture of where I live and work. These are my disclosures. I've given talks and been on the advisory boards of Tyco, Autosuture, Covidien, and Medtronic, and we'll probably go into a separate label if they ever bring Medtronic back from Ireland. Gore, Ethicon, and none of my talks have anything to do with it, but I'm going to disclose also that I'm not a big fan of the robot, so I'm kind of surprised that I'm up here. So I'm supposed to disagree with the separate training for robotics, and of course this assumes that our laparoscopic training is adequate. So I'll break my talk into the three components. Are we doing enough laparoscopic training? Should I even be up here? Do I know anything about robotics? And then finally, is specific robotic training necessary? Which, thank goodness, will be the shortest part of my talk. I've been privileged to be on the SSAT, where we're looking at advanced GI training. And as part of that, one of the members of the committee, who's also my partner, looked at the Resident Review Committee for Surgery, and these are the latest data. And these are the total number of cases that residents applying for their boards list as senior and as trainee surgeons, as senior trainee surgeons. So they finished their residency across America, and of course there's a large variation with 55 appendectomies, 10 diagnostic laparoscopies, and cholecystectomies about 112. And these are medians. But they finished with 7 anti-reflux. Thank goodness for sleeve gastrectomies and bariatrics, because they finished with about 10 partial gastrectomies, 22 colons, which they're going to do half of in their training, and 1 splenectomy. Bringing a robot in, so I'm going to digress, Santi, for an operation like a Heller myotomy, which is approximately $11,000 in the United States per year, is going to be a big expense. So it's pretty clear to me, if you look at these figures, how competent we're developing people in advanced laparoscopy to go along with the counter-argument of the first debate. So we're the two little guys up here with all the ex-presidents. So it's pretty obvious to me that we're not teaching advanced laparoscopic proficiency in any way at the resident level, so this debate is kind of very superfluous. This is no news to anybody, particularly our residents who have already figured this out, so that's why they're doing fellowships. And I'd like to look a little bit at how many robotic surgeries we're doing. Here's a graph of a snapshot from my iPhone of the general surgery news. By the way, we do about $4.5 million. No, we do 4.5 million operations. And we do a little bit over 100,000 operations with the scope. Of course, that graph is going up and has continued to rise. The incremental cost is $3,000 to $6,000 per operation. And again, this is not the capital investment. And where are we doing it? We're mostly doing it in the United States. 79% of all procedures are done in the United States. 1 in 4 hospitals has a robot. Actually, in my hospital, we have 4 robot rooms out of the 19 rooms that we run on our inpatient floor. But do I know anything about it? Well, there's a picture of me standing top, I guess you're looking top right, beside my former partner, Michel Gagné, and a group. And before many of my residents were born in March 1994 in the Lancet, we used a robot to interact holding the camera as a laparoscopic to go along with Dr. Sharon. We didn't even have Palm Pilots in those days. And the other people in the photo is Richard Horteau was an engineer, and our fellow at the time, Eric Bégin, who was the fellow of the same fellow at the same time as Adrian Park at that time. We got 2 publications out of it, same authors, added somebody else, and basically said that you could use this. We did some Nissens and some other procedures in animals. And actually at that time we thought we were going to do an ulcer operation, so we did that in animals as well. And so actually it did something in laparoscopic. And then about, if you look down there, highlighted in red, I actually trained and got my certification on the intuitive surgical in 2002. So I realized way back then that this was not the greatest thing. How old were you in 2002, Santi? Were you even in medical school? But Dr. Talamany is much more of a pioneer, and he's the guy that I'm arguing with. And that's not a picture of Talamany. That's actually, if you recognize from the back, that's another esteemed member of the podium. It's Dr. Horgan, who's on the console there. And it will be difficult to prove significant differences between robotic procedures and laparoscopic procedures, since the size of the incision is roughly the same. The size of the incision is the same, how much you cost to put your instruments in. And if you do a snapshot of PubMed, he knows way more about robots than I do. A lot of publications over the years, some of which he quoted already. So I'm going to lose if I talk to robots about Dr. Talamany. So I'm going to circle back saying, you know, yeah, the guy you put up against me, Dan, is much more brighter and stronger and able to leap tall buildings. But the real question is, are we doing enough laparoscopic training? And it's obvious we're doing the basics, but we're certainly not teaching residents enough laparoscopy. I probably know a little bit about robots, enough to stand up here and talk about it. And the question really now becomes, is specific robotic training necessary? And here's a busy graph, but this is the breakdown of the tasks that you were talking about. And there's about 15, or actually 22 tasks here. But the difference between laparoscopy and robotics is essentially setting up the console and manipulating the different instruments. So you have to position your trocars different for robotics because you have this big ungainly monster that's sitting in your small OR. You have to be able to dock the robot. Although when we trained in 2002, we were the first group. At that group, I was actually partners with Dr. Sharon here, and we brought our whole OR team. And that was the first time, actually, that someone had actually brought their whole OR team to the Hackensack Training Center, because we said the surgeons aren't going to place that, the OR staff will position that robot. Docking the robot. I think the real big difference, again, with scaling of motion and repositioning is being able to clutch. And an instrument exchange should be done by a nurse. We use an intern. And now the fourth arm control, which is obviously not in all models. The rest of what you're doing pretty well looks like FLS to me. These are robotics, cutting the circle and doing the sutures and doing the peg transfers. So I'm not sure that you need to train anybody in those parts. A sort of similar graph to what my esteemed debate colleague was saying, but there's not a lot of difference between the robotic curve and the laparoscopic curve in terms of numbers. And if you're learning the laparoscope, it actually makes you experiment. Laparoscopic surgeons can do this a lot quicker than people learning it from the baseline. So this is published literature, again, in urology. And I like this article that just came out 2 years ago, Do Laparoscopic Skills Transfer to Robotic Surgery? And if you look what's circled in red there, laparoscopic skills appear to be readily transferred from the robotic platform. So mostly robots just make good laparoscopic surgeons better. If you look at the conclusions of the studies out there in the table in the previously cited journal, it's too small to read back there, but essentially all good laparoscopic guys and girls just get better if you put a robot with them, but if you can't do the laparoscopic part, you're not necessarily any better. We've actually published, my junior partner is Che Guevara Afane, who is the second author here, and looked at general surgery training in robotics in our institution, our residents improving their skills. And they actually show minimal improvement during the course of their training, although laparoscopic experience is correlated with advanced laparoscopic robotic task performance. So essentially, with the current robot, once you learn how to do laparoscopic, you can transmit those skills. You just have to learn how to dock the robot and be able to sit on a console. Again, if they do something wrong, they get off the console. I think our training paradigm needs to be fixed because we don't have a robotic formal skills curriculum. But I think as we are learning how to teach better, you can look and say that skills are in development. The optimal method of surgical education is integrating individualized training. So quick learners will learn quickly, slow learners will learn slower. And here's my conclusion, that basic robotics should be part of a resident surgical curriculum, that they should be able to dock, console, do the console settings, instrument exchange, clutching, etc. But the difference at the resident level between laparoscopy and robotology versus robotics or robots is not significant enough to warrant a separate component of the resident education. No one asked me to talk about fellows because I would have a different opinion. Just a little bit on how much this darn thing costs. This has been the biggest Ponzi scheme in the history, so it's kind of like apples. You buy one robot, it gets better, costs more. You add 2 whistles, costs a little bit more. But just so that you all know, the Da Vinci system costs about $2 million. We saw another new system on the floor, and there are other systems on the way. And here's me in robots. Sometimes it's better to walk alone with a crowd than go in the wrong direction. Thank you very much.